Welcome to Healthy Pets, Healthy Owners. I'm your host, Dr. Edmund Sulkowski. And our special guest today is Dr. Dennis Courtney. Welcome, Dr. Dennis Courtney.
Hello, Edmund.
Back again by popular demand. And our topic today is going to be on thermography, and then we're going to talk a little bit later on in the show about stem cells and the lectures that you're presenting to inform us on what stem cells do, and then plus your eye protocol treatment, which I'm going to be attending your first seminar this upcoming week. So I'm excited to learn from you on that seminar. And I hope that the audience gets out there and gives you a call and gets in there, because they'll take home a lot of information that if it's not helping you directly, it will help somebody you know, because you know somebody with these conditions.
There's always somebody that knows somebody.
Yeah, absolutely.
And confronting a health challenge.
Then we have my little Tucker and Abby here, who will just quietly sit here, so hopefully. Anyway, Dr. Courtney, we did a radio show last weekend, and that's Healthy Pets, Healthy People on AM 1250. And the reception I got after the show was incredible. A number of people calling me how much they loved the show. But I did receive a call, and we talked about thermography, but they wanted to go in depth, and we didn't do that on the radio show. So
no, we just sort of covered a smattering.
Yeah, we don't have a lot of time, so it gets kind of difficult, and when you and I start talking, we always go off on a little bit of a tangent anyway. But I thought it was important to have you on to talk about thermography and what it does in detection of disease. So would you first of all tell us what that is?
Well, thermography is a medical study that's been around for quite some time now. I'd have to say it really came onto the scene, the medical scene, in the mid-1990s.
So it's an old technology, really?
Relatively speaking, yes. But what happens is with the technology as it advances, the sensitivity and the ability of these studies to detect medical problems is just getting enhanced with each technological advancement. So the photographs of that era were relatively crude compared to what they can be today. And as technology continues to advance, the ability for the thermogram to play a role in somebody's health management or diagnosis of some health-related issue becomes better as time moves on.
Is it an X-ray?
It's exactly what it's not. In fact, it's for the very reason that X-ray procedures, although in some cases wonderful to have and very revealing, the medical profession would be really nowhere without it. But that technology advanced by Madame Curie over 100 years ago has some drawbacks too.
Yeah, over the years they've really manipulated that so that those effects have been minimalized. I can't even say that right now, but there used to be scatter radiation and intensity was stronger. Now we're able to pinpoint that a little more, and then we've removed that scatter radiation. But there is always a cumulative effect when you're exposed to X-rays.
Yeah, this is ionizing energy. And as such, the body being exposed to ionizing energy for any reason has to be taken with the precautions that are really necessary to make certain if it could be kept safe. And I don't believe there's any radiographic procedure that you could say is not without the potential at least to do harm. Because the element of the body that is harmed in every study that's ever done with X-ray technology is the DNA of the person's individual cellular structure. And the DNA, once it's altered, and it is altered with even the most minimal exposures, DNA doesn't go back to its original formation. Once it's altered forever.
You're only as good as your DNA.
So we have great power and the utility with the use of X-ray, but we often say surgery should always be kept, when we're talking about therapies, surgery should always be put at the end. And it's just an axiom of medicine that I think you and I ascribe to. Well, I believe that if there's a better way of helping to diagnose some medical issue, an X-ray can be avoided, it too should always be put at the end. And I don't think necessarily that the conventional medical community is that far advanced. I think they take the same approach you took just a moment ago, that we're so sophisticated now, we're able to pinpoint. No, we're not. I venture to say, and I probably won't be too inaccurate by saying it, the X-ray studies of today are not too much different than what they were done by Madame Curie when she originally discovered it. So it's that exposure over time with the potential of altering DNA that is a problem that really needs to be kept in mind. And if there's a better way to get to a medical diagnosis, because that's really what X-rays are being used for, some diagnostic input, then you really should be exploring it. And I don't believe we really are in medicine. I've been a proponent of thermography since the mid-90s, and I fully support it when I know it to be the better way of making these determinations. So but the medical profession isn't there yet.
And the insurance companies don't cover it as well,
and
because it seems like a ridiculous move to me. You know, I've had so many surgeries in my life and so many X-rays that I was told 20 years ago not to have another one. You know, so I try to take countermeasures to support
you're a dentist
my body. Yeah, well, you know, I had so many surgeries, and they were taking X-rays left and right for years, and literally told by the physician, do not take another one.
Interesting.
Because I had so many. And I've lived by that, and I haven't had an X-ray in 22 years.
That was a very good precaution that your doctors gave.
So thermography is non-invasive, first of all.
That's exactly right. Look, we can, through the use of an infrared camera. Infrared cameras pick up heat, right? So when the body is, and the tissue is exposed, so disrobed, we have a whole bunch of heat variations over the surface of the body. And they're actually unique to each individual, because no two thermographic studies look the same. But the fact that there are these variations, these variations should also be symmetrical. If we have a heat signature on the right, there should be a corresponding one on the left, generally speaking. And so, although the studies are unique, we're looking for symmetry, because this heat that comes to the surface of our skin is detectable through very sensitive X-ray imaging. Not X-ray, but thermographic imaging. And so we see a thermographic study displayed with when 1 degree temperature difference is expressed in thousands of colors. These are very colorful pictures. The hottest color that we're going to be able to detect is the color white. When something's white on a thermogram, that, when compared to the other tissue, is the hottest point. And of course, the lower areas of heat would be the color blue, and the entire spectrum in between the two are the variations we look.
So you actually, when you look at a thermogram, you have the outline of the body, and then you see these zones of color.
That's right.
And you're determining these heat-sensitive areas, and usually where there's a disease process, you're going to have inflammation. Where there's inflammation, the body produces heat, and that's basically what you're picking up.
There are certainly inflammation is going to be detectable. Now, it has to be at the level of the skin. And here's where sometimes thermograms would not be the acceptable way to do it. If you have a heat change deep into an organ of the body, say the liver
or lungs,
or deep into the lungs, well, that heat has to be transmitted through a number of layers of tissue to finally be expressed at the level of the skin. And sometimes either the lesion is too small, and the distance to be traveled to the level of the skin, we have no reference that something is not right here. Everything looks normal, when in fact something could be very abnormal. So the better way to use thermography is when we're looking for something that could and should be represented at the skin level. I'd have to say that one of the most common uses for thermography, and one that I fully support, is the use of thermography in the issue of breast evaluation.
And would you compare the difference between thermography and a mammogram and give us the pluses and negatives of each of those?
Well, mammograms are bad deals for women. We have a medical protocol in play that virtually is really challenged by all the literature that's out there, because when you're using X-ray to detect a cancer, pretty much that lesion must be at least 1 centimeter in diameter before it's visualizable on a X-ray.
So 1 centimeter, size of a dime in comparison, size of a nickel?
2.5 centimeters to an inch. We're getting the idea here, okay?
Yeah.
So the problem here is that we're diagnosing a lesion that's fairly advanced. By the time a cancer gets to the size of 1 centimeter, that's a fairly advanced cancer if you consider what we refer to in my office as the Courtney 1 millimeter rule. And when you understand the 1 millimeter rule, you understand the futility of a study like a mammogram, because in the 1 millimeter rule, which goes something like this, any time a malignancy has attained the size of 1 millimeter, which is pretty small, it's already metastasized. That is a major medical phenomenon, because what that therefore means is when a mammogram could really be positive, which is at 1 centimeter, 10 times beyond where it really needs to be detected, then we come on the scene and we go, well, look, we see that there potentially is a lesion here. Word lesion is a substitute word for malignancy. And we go through a kabuki dance of frozen sections, a lumpectomy, maybe a mastectomy, with the intention to try to completely rid the body of a cancer. That's almost a medical impossibility. Yeah. I'm very happy when I meet so-called cancer survivors, but I'm very leery of these ladies who've gone through such a health challenge. They feel they've beaten it, and they had that lesion in the breast, and it was detected, and they had their lumpectomies, and then they've had their chemos and their radio, but it's going to take 7 to 10 to 12 years for a lesion that's metastasized someplace else to finally reveal itself, when in the likelihood where it finally is revealed isn't going to be the breast any longer. It's going to be in the major organs of the body. And so the potential to be in a very precarious medical situation, thinking that, well, I'm rid of myself of this cancer, when in fact it's almost impossible to say that could occur.
Well, they never really even say you're rid of it. They say you're in remission, which means it just hasn't wakened up its ugly head again. And then you think about radiation, you think about chemotherapy. Those are both cancer-causing agents. And I look at cancer as a liquid in your body, and it's just able to go there and hit everywhere, go through your lymph system, go through your blood, hit and target anywhere it wants to land, you know?
How about this, Edmund? This sort of gets my goat. So the unfortunate set of circumstances and therapies that are involved with the detection of what might be a breast cancer on mammogram, which leads to the lumpectomy or the mastectomy for what's believed to be a solitary lesion. The rude awakening is, once that lumpectomy is done and the young lady emerges from the anesthetic and the surgeon is waiting there to have a discussion with the patient and her partner or husband about the success of that surgery, it goes something like this. Look, we've got great news. We were able to rid you of that lesion. It's completely gone. And of course, at that moment, the young lady's feeling pretty good about this drastic procedure. But then the conversation originally isn't over, because the doctor will say, well, by the way, your chemotherapy begins on Monday morning. And now there's a little confusion on the face of the patient, because she would say, well, you just told me that you got all that cancer when you did that lumpectomy. And the surgeon now wants to talk about what I was alluding to a moment ago, because they say, oh, we got all of that. We got all of that lesion that we saw on your study. But of course, we have no idea where the metastatic spread has gone. Mm-hmm. Now all of a sudden we want to have a discussion about metastatic spread after the one lesion is removed. No female ever succumbs to a lesion in the breast and the breast alone. The devastation of these lesions are what organs were seeded, and the most common three are liver, lung, and bone.
And brain.
And well, brain is completely unforgiving. I'd have to say the next group of lesions that are equally unforgiving are lesions of the lung. But these are the unfortunate realities of having gone through this lesion to remove it when the breast lesion wasn't really the issue ever. It was always the metastatic spread, and I don't believe we have a long enough discussion with any female to talk about this metastatic issue, which is the real issue, not the lesion in the breast. So all this energy.
Because that lesion, the body tends to protect itself and walls that lesion off, and that's why you form a tumor in the first place. So it's actually the body's protective measure. But when it spreads, you don't know where it's going to target.
And at 1 millimeter.
Yeah.
And there's really, for all practical purposes, there's never been a mammogram that can detect a lesion at 1 millimeter. So where are we with it? This is why I've been very unhappy with how mammography, I understand how we got it into our protocol, but now every piece of literature that I read are all trying to say, haven't you noticed? The intensity about doing mammograms is really the insurance companies and the doctors that used to be do one starting at age 40, you do one every year, and now it's you start at age 50, you do one every other year. We really have to consider what we're doing here, and that's why the thermogram is the better option.
Well, in the first place, with the mammogram, you have to smash the breast, compress it, which is never a good idea.
Barbaric procedure, to say the least.
And if you do have a tumor, you risk bursting that tumor in that compression. Where a thermogram is non-invasive, and we're looking at those heat markers. You know, I've had several experiences in consulting with people and made this association with root canals and breast cancers. And I'll take it a step further and tell you that if you have breast cancer, most likely you have a thyroid issue and you're estrogenic, because when you're hypothyroid, you immediately become estrogenic. Most of these breast cancers are estrogen fed. But there's a correlation between the chronic infection of a root canal and breast cancer, breast tumor.
On the same side.
On the same side. But you can actually, not with a mammogram, but with a thermogram, you can actually see a line that goes from that tooth down through the lymph system and up into the breast cancer. You can actually see a dedicated line.
I request that when my ladies are going to have a thermogram, that the first thermogram be full-bodied, because of the very issue that you raise. The dental history of a patient is extremely important, and I know that you know that the two dental issues that are highly significant are root canals and previously extracted teeth, where the American trained dentist never removes the periodontal ligament, and that becomes an issue that maybe causes that infection of that.
Yeah, that cavitation is an issue. Gum disease is an issue. Root canals are an issue. There are also, you know, and we're taught to do that. We're taught to save teeth, you know, but again, we're leaving something in the mouth that's dead. We've taken the live function of that tooth out.
No other medical procedure that I know of takes a dead body part and retains it within a body cavity.
Yeah, I would agree with that. But there are issues and complications when you start removing teeth if you don't do some type of replacement, because you end up having teeth that shift, having your bite change, have your ability to chew food change, everything changes. So when you change your ability to digest, you affect your gum, your gut, your stomach, everything can happen because you fail to keep your teeth or keep that space open. So there are important factors and there are resolutions to that, but all the studies show that a root canal is chronically infected. No matter how well the procedure is done, there's a chronic infection with the root canal.
The tooth, before you leave the dentist's office on the day that you got your root canal, is now dead because
the nerve and the blood supply is gone.
The dentist kills that tooth. If you went and saw your dentist because you were in pain, which is the real reason that any root canal is ever done, you leave the office not in pain any longer because that tooth is dead. It doesn't have a painful response. And then that dead, everything that's dead has to putrefy. So the issues of the root canal or the cavitation because of that ligament that's running behind is bacteria arrive the next day to start the putrefaction process that never ends.
Which is a natural process of the body.
But now these bacteria are contained within the body in a way that there's going to be some issue that develops because of it, and the cancers are just one of them. We're having a great discussion here. The people out there probably scared the heck out of them because a lot of people have root canals.
Well, I have a couple. I'm not rushing to take them out. I do some things to circumvent them, you know. If I have any trouble with them or I have a trouble with another tooth, I most likely will not do another root canal. And the ones that I have, if they act up, they will be taken out, you know.
Well, let's say this, Edmund.
But I will take measures to replace that tooth there.
The best way to determine if the root canal is an issue that needs to be dealt with is if you get a thermogram and you see a heat signature over that tooth, you know you have a medical issue and that something's going to have to be done about it. So when I evaluate people who've come to me, they may have a root canal, but there is no heat signature, and I won't make a big fuss about that.
Right, I would agree.
However, if there's a heat signature, which there almost invariably is, that tooth has to come out.
So you can do a full body scan for the thermogram. You can target the breast. You can target the torso. You can target the mouth. You can actually do certain areas that you want to focus on.
You get a full body. That's why I request the first study be a full body study. There's no targeting here. You're emitting heat, and that camera is so sensitive it will pick it up. So one study of the entire body reveals all the body parts, and those heat signatures are quite stunning and stark and diagnostic.
But you know, it's not covered by insurance. Some people don't have the money to do a full body because it is more expensive. You know, insurance isn't going to pay for it. But if they had a concern for, let's say, their breasts, they could come in and just do that area at a certain cost.
They could, and they do.
And you do that at your office.
Yeah, we've been for 15, 20 years now. Once a month, we have the thermographers come into the office. Women who live near my office enjoy the fact that they only have to travel a certain distance to go there. The thermography groups, there's only two in all of Western Pennsylvania. And their offices are sometimes not geographically pleasing. So the fact that they do, not just coming to my office, they go to many medical offices, is a good news for maybe our listeners here who are thinking, maybe they'd like to know more about thermograms. Mm-hmm. But I think to finally bring this into context, and we had talked about this Courtney 1 millimeter rule, and I say the drawback of the mammogram was that it's really only detectable when a lesion has acquired 1 centimeter in size. So let's take what I believe to be the real benefit of the thermogram, because a lesion of 1 millimeter,
which is the thickness of a dime,
on a thermogram lights up the size of my fist on the study. And you say, well, how can that be? It's only a millimeter. Well, what happens is that if there happens to be malignant tissue, this malignant tissue is really it's trying to get nutrition for itself from you. Mm-hmm. And it's not really happy with the meager blood supply to supply that nutrition. And so these tumors can secrete a hormone called VEGF. VEGF stands for vascular endothelial growth factor. So what happens is the tumor secretes a hormone to grow brand new blood vessels around it, to disproportionately feed it, and in so doing, it makes that lesion so small, light up with such size that it can't really be missed. So we have the benefit with thermograms we never had with mammograms.
Yeah.
In a mammogram, all you see is there's a something. You don't know what that something is. But with a thermogram, not only do we see there's a something, but we can tell by its heat signature whether that something is a malignancy before we even entered this issue.
And then when I learned several years ago, maybe it's been probably 15, when I started to learn about thermograms, and I did that in association with the American Anti-Cancer Institute that I'm a advisory board member on. The studies I read show that you can actually diagnose breast cancer 10 years before a mammogram can using a thermogram.
7 to 10 years, you heard the right, 7 to 10 years before a mammogram could ever be positive, the thermogram can, and it would allow for intervention pretty early on.
What's little known is most cancers produce an enzyme called nagalase, and nagalase it shuts down the immune system, tricks the immune system for your immune system not to attack those cells. And when you take in conjunction that's happening from the get-go, and it's tricking your immune system and allowing that cancer to grow, and then you add to the growth of the blood supply there, you're getting that tumor growing unbeknownst
unbridled.
Yeah, absolutely. So it's an amazing, and they're actually using that nagalase in some of the vaccines to trick the body to accept the vaccines. So it's kind of a scary process to me. But I firmly believe in this thermography, and I think it's great that you offer that service for convenience for your patients, you know.
Yeah, the mammogram really needs to be considered. Ultimately, it's going to be done away with. It's just that the medical institution has allowed it to be the best way, they claim it, the best way to detect the cancer.
Yeah, and they don't even know about thermography. They don't know what it is.
They don't even know about thermography.
Dr. Courtney, we're going to go to a little break here for a moment, and we'll be back to talk about stem cells and your eye protocol, which are fascinating. And we'll be back in a few minutes with Dr. Courtney. Little Abby here is asleep, and you know why Tucker got his name. He's here tucking his head. We'll see you in a few moments. Bye-bye.
Food. It nourishes, brings us together, and adds flavor to life. That's why it's important to wash hands, surfaces, and fresh produce. Keep raw meat, poultry, and seafood separate from ready-to-eat foods like fruits and vegetables. And cook to proper temperatures using a food thermometer. Enjoy! And refrigerate leftovers within 2 hours. For more tips on safely preparing foods, visit homefoodsafety.org.
Welcome back to Healthy Pets, Healthy Owners. I'm Dr. Edmund Sulkowski, and we're here with Dr. Dennis Courtney and my little Tucker, little Abby. You know, Dennis, we were talking about the thermography, and especially related to breast cancer. And I want to just bring a closure to that. Why hasn't the medical profession accepted fully thermography?
To the extent that once you make it into a medical protocol, you are enshrined. Mammography has taken itself over many years now, and they are in the medical protocol. There are hospitals with 10 to 15 X-ray machines just waiting for you to arrive. And it's been decided by those who develop protocols that the best way, in their mind, to screen for cancers is a mammogram. Now, for at least the last 20 years, the competing literature that is now made it into the medical literature takes on that battle cry directly and says, oh no, it's not. And we're still right now in a dilemma of having mammography because of all the years that it was the only way to handle this, remain, and I believe, beaten up very badly. I think those that cling on to it do so because maybe they're financially and economically tied to this. But in terms of the payoff, which is if you're a woman and you want protection, the mammogram really is not the best protection.
See, and insurance companies will pay for a mammogram. They will not pay for thermography.
It's in the protocol.
But the interesting thing is, if thermography is proven to show, and it is proven to show cancer years, 7 to 10 years before a mammogram ever could, it would make sense for the insurance companies to pay for that, because then they would avoid cancer treatments, which they're being bombarded to by being hit from the patient tapping into the reserve for the cancer treatments. So it would seem to me that they would want to
They may
engage
want
that.
to, but they don't make medical protocol. The medical profession makes a medical protocol. So you've got to dent that. We haven't dented it yet. It still remains strong. I mean, if you can go to your doctor and tell your doctor, I'm going to have a thermogram, and the response, and pretty much universally, is, what's a thermogram?
That's the response.
Then we're far away. So if a woman wants to protect herself, she really needs to take this one on. It's she who needs to decide. She's the adult in the room. So I can't worry about educating other doctors. I know them as brilliant men and women, but if you don't have all the information, your brilliance is really dulled. But we can't worry about that, because if you're the woman facing her next mammogram, you want to talk about somebody who is very attuned and wants to hear what you're saying and is willing to listen, because she has no preformed ideas about what would be better for her or not. When the realities of how bad a mammogram is are confronted with the positive of how good a thermogram can be, the conversation probably after 30 minutes is able to create a woman who's very strong now. She's resolved, she's resolute, and she will not be dealt with and dismissed.
Or intimidated, which tends to happen.
Yeah.
When you and I lecture, when you and I talk to people, we talk about empowering and taking charge of your own health. And that's what it really should all be about. Nobody should be in charge of you but you. So the cost of this varies. It's an out-of-pocket expense. You're paying it yourself, but it's $250 to $700 some dollars, right?
For the breast alone, and I say the first study should be full body, and we're talking about at least, and I'm not involved with that because I don't do thermography. I have people that come to my, but I think the going rate is something like $450 for the full body. And once you have the full body done, which takes into account all the dental, that's the real key in terms of long-term predictions, then all you need is to do the chest component from that point forward. And that's around $200 to $250.
Yeah, so it's a night out, dinner night out in a movie, really. So I would emphasize you need to look at it that way. You need to look at getting that done and having proper diagnosing done. Doc, that was a wonderful information given. It was absolutely wonderful on thermography, and especially associated with breast cancer. But you're doing so much, and you've been on Healthy Pets, Healthy Owners, and Healthy Pets, Healthy People, talking about your stem cells and talking about your eye protocols. I would like you to talk some about your eye protocol right now, dealing with macular degeneration and glaucoma, and kind of tell us briefly what each one of those diseases are and how you treat, and then the seminars that you're giving to educate the public and empowering the public.
Yeah, so switching gears as we do so often, you and I, another avenue of pursuit of mine, and it's been a passion of mine for years, is treating very serious eye diseases. And as a non-ophthalmologist, that's a little rare to have me speak about how it is that we actually can fix these problems. So when it comes to the eye, we've got 3 divisions that I think the public can catch on to. One, the anterior chamber, which involves the cornea. All that could go wrong with the cornea is pretty much put in the hands of the refractionists, so the optometrist with the glasses and the contacts, and even if it needed to be a corneal transplant, that all appears to be well covered by the eye community very well. And I don't venture into that arena because they're already doing pretty good. I start picking up when we get to the middle part of the eye, which is the chamber that involves the lens, because we have a pretty common condition in the mid part of the eye known as cataracts, which is opacification of the lens, which happens over time and usually rears its ugly head in the 6th decade of life and beyond. Currently, we have a way of resolving the problem, and by the way, it's a pretty good resolution, where they say remove the cataract. You don't remove the cataract, you remove the lens, and you throw it away.
That's a surgical procedure.
You remove the lens, but you put a synthetic one in its place. The surgery is done very well by these highly skilled ophthalmologists over time, and the success rate is well into the 90% plus.
What about that 10%?
Well, I see that remaining 5-6%, and to them, I hear things like, worst decision I ever made, worst day of my life, because their result wasn't anywhere near what the remaining people's results were. And so this is back to what we said in the first segment, which was always put surgery at the very end. And in the conventional medical world, there's only one treatment for cataracts, and that is take the lens out and throw it away. I say there is another step. These eye programs that I have are able to literally begin to deteriorate the opacification and at least potentially take the threat of surgery out of the equation.
So is this through medication, or is it a procedure that you do 1 day, 3 days, 5 days?
Well, the thing with the eye programs is that I do not use drugs. A little odd, maybe, coming from a medical doctor who has a prescription pad. My prescription pad collects dust. I just don't choose to use them. The things I'm using are alternative approaches and promoting health, and that is the real key. In most of medical treatment, we have 3 things. We have drugs, surgeries, and procedures. When it comes to rescuing the eye, neither of those 3 will ever be able to get the health of the eye back. Mm-hmm. Let's move to the back part of the eye, because I believe this is where there is no other option. At least the lens could be removed. And so that is an option. And 90% of the time or greater, a very good option. When we move to the back of the eye, we're in a whole other category, because the diseases of the retina, and they're well known to the listeners out there.
Like glaucoma.
Glaucoma, macular degeneration, diabetic retinopathy, retinitis pigmentosa. The list goes on, but the fact that they're from the retina means there is, and I don't envision there will be, a treatment to correct that problem. This is a blow to the gut of a patient who may suffer from one of these diseases, to be told by their very intelligent eye doctor, look, you have MACD and
wet or dry MACDs.
Of course, there are 2 kinds, but it doesn't matter what kind, because there's no treatment for the wet or the dry.
Just symptom relief.
There's not even any symptom relief. For the wet, which there's bleeding, that's why it's called wet, right. They have an injection into the eye to put a clot so that bleeding stops. But that by no means is able to rescue you from the disease, and 30% of the time you get global atrophy where they injected you. So that's not really a good thing to do.
Just coming at my eyes with a needle would enough to make me run out of the office, you know.
So when it comes to the retinal diseases where there is no treatment option even available, it's nice to be able to say, oh yes, there is. We can stop the further progression of this disease, and we can reverse that disease and get vision back that has been lost. because we're not going to be using those three tools. There are no drugs here, there's no surgery, and there's procedures. Our approach is to promote health. And you can promote health to such a degree in the back of the eye that you can rescue it from further damage. And these now famous, we call them 3-day programs. They happen in my office once a month on a Monday and Tuesday and Wednesday, 3 days. We will get patients with the varying diagnoses that applied to the retina. They come in, and on Monday, the first thing we do is to find out what their vision really is. Then 3 full days, 9 to 5, of one alternative modality after another. And on Wednesday, the last thing is to re-examine them and find out how much improvement they have.
So do you use microcurrent therapy in this process?
There are a host of frequency-specific microcurrent is one of them. I'm sure the public is not too attuned as to what FSM is all about. It's truly a great rescuer of the microvasculature, which is why this thing is so predictably possible for anybody in their disease. In fact, we bespeak of a statistic I'm quite proud of, and that statistic is that for those with all those serious eye diseases, especially even when there's no known conventional medical treatment, 85 to 90% of all patients participating in this program have a substantial improvement in their vision in 3 days. 3 days. I know it sounds fantastic.
Well, that could be why you were selected as in the top 20 of alternative physicians in this whole country.
And by the way, it was.
And you don't talk about it, but
about
Dr. Courtney was selected as one of the top 20 physicians in the country of alternative medicine, which is a big honor to have. And you also run a clinic, probably not known to the people in our area, also in Florida, that's just dedicated to these procedures for eyes.
Eye programs and stem cells.
And you're doing stem cells now also down there.
That's right.
And so you've pretty much limited your practice to those two things. But you and I work together with some thyroid patients as well.
Up north.
Up here, yeah. So, and as far as I'm concerned, when you're taking care of the thyroid, you're taking care of everything.
Everything's being taken care of.
So exactly. It's the totality of everything you do for wellness and health, which is, we're so fortunate to have you. Would you tell us the difference between glaucoma and eye hypertension?
Well, of course, in a condition of glaucoma, there's a fluid that's made in the anterior chamber of the eye that then has to be drained from that chamber through a drainage system. And that drainage system gets clogged or restricted and pressure builds in the front chamber of the eye because the fluid,
like a balloon swelling.
Yeah, the fluid continues to be manufactured. It just has no way of relieving itself, and the pressures are elevated. Intraocular pressures rise, and they impress that pressure increase to the back of the eye. And with the pressure increase transmitted to the back of the eye, it impresses on the microvasculature of the retina, and the retina dies.
And that leads to blindness.
And once you lose these nerve endings of the retina, they pretty much, with conventional management, are unrevivable. Now, we do have some medications in glaucoma to try to alleviate the pressure problem. That is true. And we encourage the use of these eye drops to try to get this pressure into a realm of safety. However, there is nothing for the glaucoma, which is a disease of the retina. The damage done is done, and it's going to be continued to be progressive no matter what kind of eye drops are being used. So one of those retinal diseases without any known, for sure, cure, there's just no way of stemming the tide of this damage. Mm-hmm. Glaucoma, by the way, is the #1 cause of total blindness, total blackness. In a patient with glaucoma, the visual fields get lost in the periphery and they close in on you. And so in a way that's undetectable and unnoticeable by you, you're losing this and you don't know it because it's happening out here. But one day what happens is You've lost it all out there, and now we're somewhere in here. Somebody calls your name, and you realize you have to turn to actually see where this is coming from.
Yeah.
And you've lost all this, never in the conventional world to get it back again. I claim, oh yes you can. Because
You heard it here.
we can revive the retina to get this tissue back to health. We don't use drugs or surgeries or procedure, which are designed to combat disease. You can't beat the disease by trying to take it on through those therapies. You can only beat disease by promoting health.
By using your body to fix itself.
The right nutrients, remove toxicities, and give it a blood supply. These are the three battlegrounds. No matter what you see me about, I'm going to be involved with those three arenas for whatever body part or body organ is involved. It just happens to be when you concentrate on the eye, you can have a major impact in 3 days. And that's what these eye programs are all about.
Is eye hypertension and glaucoma the same?
Yes, an elevated pressure. Intraocular pressures usually run in, 8 millimeters of mercury. They do tonometry when they do an exam of your eye, and it tells us what your pressure is. In glaucoma, I've already had people with pressures 25, 30. With that magnitude of elevation, damage is being done, irreparable damage with a conventional treatment, and we have to rescue them. We encourage the use of those drops. There are even some surgeries to put holes in the retina to alleviate these pressures, and I'm with all of those therapies if they're needed, if they can't get the pressure to be decreased. But I contend that glaucoma is a disease of the retina, and that damage with any conventional therapy, there is no therapy for it.
Does any hereditary aspect play?
There are components to every one of those diseases that have a hereditary link, but honestly, they don't usually rear their head until we're reaching our 6th decade of life. So we don't usually find glaucoma in a 25-year-old. We find them in a 65-year-old.
But it's bad if you find it in a 25-year-old.
If we're to rarely find it, it's an ominous thing to find, but still, I contend that should be as correctable as it would be if it was found in a 65-year-old. Yeah. You have to have a different approach. Our therapies aren't effective in restoring health. They're only an attempt to combat disease, which it can't do.
So you're offering these lectures every month, and for example, you're having one held on February 13th at 7 p.m., and you need to call to make that reservation, but it's free. It's a lecture at the Marriott, Airport Marriott off of Montour Run exit.
Montour Run. 2018 is the year of education.
And you're going to be doing these lectures every month.
Every month?
About the second week of the month, right around there.
Somewhere around there.
Tuesday, Wednesday of the month.
Next one's coming up is on February 12th, but of course
well, that's for your stem cells. We're talking about the eye protocol. So then
February 13th.
13th at 7 o'clock, and I will be attending that one.
And you'll walk away very enriched.
Yeah, and I know a lot of people that I've talked to are signed up to go, so I'm excited to learn there.
We should give our listeners the opportunity, by the way, if they should want. There's an open invitation.
Bring a friend, absolutely. I think the doc wants a reservation to know how many seats to set up, but we could always get those. You could always get those set up.
Oh yeah,
afterwards.
they're very amenable out there at Pittsburgh Airport, Marriott. But I would say if you're listening to me, and you suffer from such a disease, or it's more than likely is if you don't, you know somebody that does, and they're not aware that there's actually a treatment to reverse that disease. I would invite you to attend that lecture on the 13th of February,
7 o'clock.
Tuesday night, 7 o'clock. And just to reserve a seat to give us an idea of the count, the number to call is 724-749-4558.
And I'm sure they'll put that up on the graphic, and people could always get a hold of us to get that, or just call your office on your office number.
And they'll pass it on to you, too.
Absolutely. So I think it's a wonderful lecture to attend because when you go blind, without your eyesight, you have such a restricted life, and you don't want to lose it. So if you can curtail these problems, you need to get them taken care of as early as you can upon diagnosis. So
the earlier the better.
Become educated, become empowered, invite a friend and bring them along. So you do the same thing. So let's kind of talk now about stem cells. And I know there's possibility of stem cells for eyes, but let's talk about stem cells for joints. What are stem cells?
Stem cells, as we've mentioned many times before, we keep seeing each other in a host-guest relationship. I always enjoy it. But there is a way to harvest cells which are blank. These cells haven't determined what cell type they're going to become.
Which means they can become anything.
They can become anything. In fact, we all emerge from stem cells. At conception and with the divisions, those initial divisions for at least the first 6 weeks were all without a cell line declared. They were all stem cell. So we emerge from that.
So those are undifferentiated cells with no identity is the easiest way to look at them.
And then when about 6 weeks rolls along, they declare a cell line. Some declare to become nervous tissue, muscular, the various organs develop. And once they've declared, there's no going back. And they will continue to develop along the line that was so chosen. Well, this is how we got here. This is how we've emerged. And after 9 months, everything's fully formed. A life is created and entered into the world. But we actually can harvest stem cells and give them for our medical breakdowns of our lifetime, our medical challenges. One area that this has been very successful is in the area of joint disease. The field of medicine that's emerged, we refer to as regenerative medicine, because it's possible to regenerate a new knee joint. By the way, the number one request of me is the knee. The number two is the hip.
Yep. And number
three is the shoulder.
Yeah.
So these 3 areas for sure, plus every joint is up for grabs here. If we take these blank cells and deposit them in the joint itself and allow them to land randomly on the diseased joint, and upon landing, they declare to become a new and healthy one of those.
So they don't take on the identity of the disease cell, they override the disease cell, basically.
Well, they can only read the code called DNA. And that DNA code is the same for you today as it was when you first walked in the door, how many years ago? That code determines what cell type it is. The pathology you sort of brought along yourself, you contributed to that. So people say to me, well, look, what if you're going to give me a new joint, am I not going to still develop disease? And I say, well, you're 73 years old now, hypothetically, and it took you 73 years to get to this point. How'd you like another 73 years? Because if you're going to expose yourself to the same stresses and the same deficiencies and everything else, then you're going to have equal ability to damage that new joint, but that's 73 more years.
Yeah.
So they get the message real quickly.
And so there's a difference between the type of stem cell that you put in as to where it's harvested, meaning taken from. So would you give us a brief description of your stem cell harvest as opposed to maybe some other stem cell
The industry began in 2005 with the autologous stem cell. And that is where you're both the donor and the recipient. So using either your body fat or your bone marrow, they harvested your cells, then they manipulated them to extract the stem cells alone, and then they gave you those stem cells. That was 2005. We're in 2018, for goodness sake. And in 2018, we've got a new player. That player is never going to be the autologous cell again, because to be quite honest, we don't have any stem cells to speak of after the age of 15. No one ever looked at a 15-year-old as over the hill. But when it comes to stem cells, you're over the hill. So to use those cells in a 50, 60, or 70-year-old is literally absurd now. We have a new place that we get these from. And for the last 4 or 5 years, they're called heterologous. They come from newly delivered babies by scheduled C-section, where we harvest the umbilical cord and extract seething amounts of stem cells. This newborn is loaded with stem cells. They're processed, they're frozen until I call up to order that they be sent to me.
So what about rejection?
Oh, interesting. The phenomenon of rejection reaction, which as Pittsburghers we know about how organs can be rejected. You get a transplant, you get a lung or a kidney or a heart. The next day, we got a problem because your body recognizes that it's foreign, right? What happens is that these cells harvested from these babies have immune privilege conferred. That's the term we give to the phenomenon that they cannot provoke an immunological reaction.
Response.
So there will be no tissue rejection.
So you accept them as though they're yours.
There is no tissue reaction with 3 body tissues, and one of them is umbilical cord cell.
Awesome. You're giving this lecture, Stem Cells 101.
Got to come out to hear that one.
That is February 12th.
That's on the 12th.
7 p.m., Airport Marriott.
Pittsburgh Airport Marriott.
That number again, 724-749-4558 for a reservation for this free lecture.
Come on out.
Come on out. And you're going to be doing those monthly, so always call the office to get those dates. Listen to Healthy Pets, Healthy People, because we're going to be talking about those dates every show that I do on the radio. That's AM 1250, The Answer, every Saturday morning from 9 a.m. to 10 a.m. In fact, Dr. Courtney was my guest this past weekend. So we're at the close to the show, Doc. What a fast hour it always is with you, an informative hour. I want to thank everyone so much for watching Healthy Pets, Healthy Owners, and give a listen to Healthy Pets, Healthy People, AM 1250, The Answer, every Saturday morning from 9 a.m. to 10 a.m., live call-in show. I also want to thank Tucker and Abby for being such special little dogs. Dr. Courtney, thank you so much.
Thank you, Edmund.
Thank you. We'll see you next time on Healthy Pets, Healthy Owners.